So the first question that we have is from Ronnie Elway, and she says, thank you for this talk, Dr. Mittman. The three sources of knowledge, research, science, service users, and service providers assumes that researchers actually know who these important service users and service provider stakeholders are. How would you suggest that early stage implementation researchers who may not be embedded in research settings begin to identify these stakeholders and make plans for engaging them?
So, this, as with many other issues, probably would benefit from the snowball effort, a snowball technique that we start with, the patient groups that we know are actively involved in care. And again, I would, refer to PCORI and anyone who's conducted PCORI-funded work, where this is a key goal and lots of accumulated experience in identifying and recruiting and working with and benefiting from patients and consumers. On the clinician health professional side, and perhaps more challenging on the external side, things are not quite as straightforward. The study sites, of course, are the first place to start in terms of identifying the stakeholders involved in the care process. And in many cases, they, or perhaps more often, the leaders of the institutions, know something about the external groups. So there are different regulatory agencies, there are different, obviously, professional associations, the medical societies and other health professional societies. And again, a snowball technique where, we ask them with a focus on the frontline clinicians as well as the organizational leaders, who are the groups, the entities, the initiatives and activities that you look to or that you were aware of that influence your care, in ensuring that we know all of the contextual factors and stakeholders that influence the care processes and outcomes that we're interested in, and recruiting them to collaborate with us, at minimum some sort of advisory capacity where we would meet with them periodically. But ideally, in the same way that PCORI encourages active collaboration with patients and consumers, to have those key stakeholders actively involved, and I think will make a big difference in our ability to deal with more of the factors that are holding those boulders in place, and identify and leverage more of the multi-level influences that we need to deal with in trying to change professional practices.
Thank you. I think many of us on this webinar are rehabilitation researchers, trained in clinical research and trying to make the transition to embedded researchers. We have a question from Shoshana Sofer, which I think is really relevant to this issue, is what is the minimal level and type of support that a researcher needs in order to carry out an implementation study, which is highly complex and expensive?
So I think the short answer is the required level of support is always more than we have access to, both in terms of moral and logistical support and legitimacy endorsement, but also equally or more importantly, funding. This is a dilemma, and there have been some discussions within one of the groups that I sit on, the NHLBI Board of External Experts. It's a group right before NHLBI Council. We've talked about the fact that for these kinds of studies, some equivalent of the wet lab that our basic science colleagues benefit from, a fair amount of the overhead funds, as you all in academic settings know better than I do, within medical schools and other universities tend to support the purchase of, costly equipment in the space and the, really the resources that are needed to conduct effective basic science research. We have the same kinds of needs to have our own laboratory and infrastructure, and Shoshana alluded to, those of us who work within health systems as embedded researchers, have the health system leaders and access to the delivery sites and the frontline clinicians, right down the hall oftentimes. But that's not the case if you are a sort of virtual embedded researcher. An academic, for example, working with a practice-based research network or trying to recruit your own site. So recognizing the need for that kind of infrastructure and all of the resources, making the case to the funding agencies that support is needed, trying to find, to the extent possible, again, something that we as embedded researchers often are able to recruit, and that is the in-kind contributions. Within our Kaiser Department of Research and Evaluation, and similarly within the VA Query program, it's often possible to convince the health system leaders that our embedded research will, as it's intended to, contribute simultaneously to outcome improvement and improvement in healthcare system performance, and to scientific knowledge, generalizable knowledge. And if that's the case, then tapping into health system resources to support the quality improvement half may be possible. But again, academics often don't have the benefit of those in-kind resources. So, I know that, Shoshana, this is not a direct answer, but obviously beginning with a clear understanding of what is needed, and then beginning to search for forms of support in order to provide, to the extent possible, supplementary resources to allow us to leverage the relatively limited funding that we're able to get from funding agencies is, I think, the way to get started.
Yeah, Susan, to touch on this question, is it expected funds that are used for small-scale powered studies, findings rarely matter?
So you cut out a bit. Let me go to the chat and make sure that I or maybe it's at my end that cut it out.
It was a comment from Susan.
Yeah, no, I see it. Yeah, so actually, no, I appreciate that comment. It does allow me to make a statement and point out something that, I believe is important in this field, and gets back to a debate that I had with Martin Eccles, who co-launched the journal Implementation Science with me. We used to spend a lot of time debating the value and obviously the publishability of small pilot studies. And he would often argue the evidence-based medicine perspective, which is if a study is small and underpowered, and if the meta-analyses show us that there's a large stable effect size estimate from prior studies, conducting a new small study is not going to change anything, and it's not worthwhile. And therefore, we shouldn't publish small studies, and especially because they're often underpowered, and the meaning and the validity and reliability of any estimates of effectiveness are limited. The counter argument that I would offer is that if we're dealing with a new highly innovative intervention, an implementation strategy or a clinical intervention or delivery program, we actually don't want to start with a large multi-year, multi-million-dollar study where we have an unproven or only weakly proven idea. So in that particular situation, we actually do want to start with the small pilots that are likely underpowered, just to assess basic feasibility and to develop some preliminary evidence to whether this seems to be a promising idea. Those studies, I would argue, should be published with all of the caveats, and they may be publishable as short reports rather than full empirical studies. But I think converting that kind of thinking to the idea of resource investment again is that in many cases 5 very small studies of $100,000 each are in fact much more valuable than a single $500,000 study that tries to do everything. But it does depend on the existing evidence and where you are in the pipeline of efficacy to effectiveness, of strength of evidence, and ultimately it's an issue of contribution to knowledge. If the existing evidence or knowledge base is small, a small study represents the next important contribution. If the existing knowledge base is large and robust, then only a large study will represent a meaningful contribution to knowledge.
Fair enough. Here's a question from Jason Benechuk. How should we interpret implementation study findings that report beneficial changes in clinician attitudes and beliefs, combined with the lack of beneficial changes in clinician behaviors and outcomes?
So in my view, any implementation study and all studies of complex health interventions have to begin with an explicit causal model of the sort that I'd illustrated, my hypothetical model of guideline adherence. And we need to not only have an a priori understanding of essentially how the world works, what the key factors are and how they influence the ultimate outcomes, and the knowledge and the ability to look inside the black box and understand the mechanisms of effect. So not only do we need that a priori understanding and explicitly depict that, But we also need the data collection and analysis activities that allow us to measure the intermediate outcomes, the mediators, examine the moderators. And, to me, it's useful to think of that kind of diagram as a set of boxes that are attached by rubber bands. And we know that if we shake only one of those boxes at the far left-hand side, the likelihood that we will see any movement in the outcome on the right-hand side is very slim, especially if the boxes in between the beginning and the end are held in place by other factors. So, and again, it's the mousetrap analogy. You have to watch each of those causal links in the overall chain and understand that if your knowledge or educational activities did improve knowledge, but the practice didn't change, is that because the other influences on practice change did not move and we're holding that knowledge in place. I'm sorry, that practice in place. I'm confusing the different boxes. So again, it's all about understanding causality, and as I said in the lecture, not understanding whether an intervention is effective, but understanding how it achieves its effects. And that's the guidance that we need in order to refine and improve the intervention next time. One more point, if I could add, and that is that too often when we see a large study with a complex multi-level or multi-component intervention that doesn't succeed in achieving the desired effects, our conclusion is that didn't work, let's try something else. When the conclusion should be, that didn't work, let's understand why not. And let's try to determine what we should do to make it work better. How do we refine it? It's the chemical formulation idea. We have the ability to modify the chemical composition of our interventions. Our research should lead us not to throw something out altogether, but instead to understand where along the causal chain things broke down, didn't work as expected, and what we can do to refine and tweak the intervention next time to see better effects.
So I think that question from Danny follows directly on this, which is when designing and testing multi-level or complex interventions, there's often little evidence on each component and the combined effects. So thoughts on teasing out the individual effects and the needs for each component so that the most parsimonious intervention could be identified.
So one preliminary thought. So, I threw in my, scattered throughout my lecture, various comments on how we shouldn't be using the term core components as it's typically used. We shouldn't be using or striving to develop manualized interventions. Along the ideas and approaches that I think we need to discard is the idea of trying to identify the active ingredients. Because in many complex health interventions, all of the ingredients are active and the effects are more multiplicative than additive. So if you think about a simple additive model where you're trying to get to 100 points of effectiveness, and you have your educational activities that contribute 20 and your financial incentives that contribute another 20, you add a few more in and you get to 100. If you end up with a 0 on one of those dimensions because you don't have the ability to change financing, if you double up on the educational activities, you could still end up with a high total score close to 100. But let's suppose instead that the effects of those intervention activities are synergistic. And the way that you compute this in a mathematical mode is by multiplying. You could get your 20 times 20 times 20 to get to the top. But if you have a 0 in any one of those, and again, this is the idea that oftentimes intervention activities are necessary but not sufficient, with an emphasis on the necessary. If you have a 0 somewhere, you may end up with a 0 total effect. Even though you've managed to change knowledge and attitudes, you see no effect on behavior. So, it gets back to the argument that we need an explicit causal model, and we need to understand how these different intervention activities or components combine and interact, and how there may be some that do have relatively separate, additive, independent effects where we could actually drop them. But if others have multiplicative effects and we drop the patient education altogether, then we may end up with no overall effect. So explicitly describing the hypothesized causal mechanisms and model, testing and refining those is really the core I think of this kind of research as a way of answering that question and trying to, identify a more parsimonious multi-component intervention.
Thank you. There's a question here from Pam Duncan, and she would like to ask it orally rather than in the chat. I see that that's coming through Cheryl Bushnell's login. So see if you can unmute, Pam, and so you can ask your question. And if you're not able to unmute, then Maggie, see if you can unmute Cheryl Bushnell.
And Linda, in the meantime, I did see the other question from Ronnie Elway at 3:39. I see Cheryl's unmuted, or Pam.
Okay, hi, I didn't realize, sorry, didn't mean to, oh no, I'm coming on with Cheryl. Hi, Brian, this is Pam Duncan. So
Hi.
let me give you a specific example that we're struggling with ourselves. So in rehab or in behavioral interventions, they are complex, right? And I keep hanging on to this concept that you said, well, it depends. So let's take blood pressure as a model, is which one Cheryl and I are actually looking at. So in order to control your blood pressure, you need knowledge that it's a risk factor for untoward events. You also, the major evidence-based interventions are obviously medication management, physical activity, and decrease your sodium in diet and decrease your weight, control your diabetes. So this is an example that when we go out and we try to control blood pressure, we package these interventions together. And if, for example, I'm taking my medicines, but I'm not physically active, if I'm testing this in population models, obviously I would, physical activity would affect me, but if you're not taking your medicine, it's medicine. So we design these complex interventions trying to individualize it. But then when we put these forward for scientific review, we get the question back to us. So, well, how will we know which one of these components contributed to your success? How do you respond to that?
Yeah, I think to me, the first question is, somewhat overly simplistically, but I think it's helpful. Do the effects, are they additive or multiplicative? Is it possible to, titrate the medication to the point where, you get most of the effect that you need, even without physical activity? Or is it possible, as it is with prediabetes, for example, to, through physical activity only? But in other cases, you need both. Ideally, we would have the sample size, but also we would plan the analytic strategy in a way that would answer those questions. Oftentimes we, fear that, the sample size for these kinds of studies, would be, completely infeasible. I think in some cases, the concepts of core functions and forms help out, because that does allow us to take what might appear to be a large number of different versions of an intervention and reduce them to a smaller number. So if you have some patients that are walking and others that are swimming and others that are, using different forms of physical activity, I don't know that we need the sample size to determine whether swimming is better than walking. We need the sample size to examine the relative contributions and the possible interactions between physical activity and medication. So I think, as is typically the case with a grant application, recognizing the issue and sort of preemptively addressing it and proposing a strategy that, does show reviewers and, the research team itself that, these are important questions and the study is powered to answer them. But, in my mind, again, it gets back to this idea that asking the question and powering a study to determine whether these interventions are effective, yes or no, is just not a useful thing to do. And I've been waiting for a fellow or someone to come along and take on the challenge of reviewing the last 10 or 15 years worth of large CMS Medicare demonstration programs, the vast majority of which, as I understand it, have led to, an average effect size estimate that's close to zero. And if we can demonstrate to our funders and our colleagues that, pursuing an answer to the question, is it effective, is just not useful, that may help us to go down the path of planning the larger studies with the sample size sufficient to answer what are ultimately the more important questions, to confront the heterogeneity rather than assume that it's not going to exist.
Okay, thank you.
Great. And now we did have one other question that you saw from Ronnie Elway, and I'll read it. She had to jump off for another meeting. Is another problem in studying complex health interventions that we are not quite sure if the intervention is being delivered with the same intensity, dose, et cetera, across the board. This is one of the challenge of true implementation voltage drop and program drift, AKA Chambers et al. 2013. How can we try to prevent these from happening when it's a true implementation as opposed to a hybrid trial?
Sure. So this gets at one of the key challenges in trying to take the approach that I've described in studying complex health interventions, and that is to think about core functions rather than forms. Because it's true that for a particular clinician-patient dyad, 5 minutes of education is as effective as 20 minutes of education for another dyad. So, a traditional way of thinking about fidelity and measuring dose and intensity, I would argue, is not necessarily the right way to go. What we want to do is have the ability to measure whether or not that core function was addressed or that underlying goal was met. But there's a problem in terms of how you measure that. So you could take the position that, if the patient showed sufficient knowledge gain, that dose of education was enough. But, we can't really measure intensity and dose and other measures of our independent variables on the basis of dependent variables. So we have to have some independent way of determining the required dose and intensity of each intervention core function to use that in the way that we traditionally use measures of fidelity in research. And no one that I've talked to has an answer as to how we do that. When you allow for the variability that the core function form approach implies, that you can provide different types of intervention activities in different settings with different levels of intensity, as long as they all carry out the core function equally. So I think I'm answering the question with another question and a challenge. I agree with the premise, though, that there are variations in what I would argue and prefer to view as fidelity to function, but how we measure those and how we determine when we've achieved sufficient fidelity to that function versus too little intensity or dose is not at all clear.
And I think we have one final question that I'll read. I think it was in a private chat, so it's from Vincent Moore. And he says, the multi-level intervention model assumes that you really know the causal lines of influence that determine, if only partially, why an intervention did or didn't work. Unfortunately, the evidence base is really that complete, and so we are really relying not on empirical estimates, but our impression and suspicion about what levels are and are not necessary, like a DAG in epidemiology. These are hypothesized relationships and not subject to empirical testing. The problem is not just, are they additive or multiplicative, but rather partially substituted for some rather than for the other.
And in some cases, factors that we're not even aware of. So, one response that I would offer is a bit controversial, and that is when we think about research in traditional drug trials, our goal is to, develop an estimate of the effect size, the pooled effect size. So it's really a focus on evidence with a capital E, meaning empirical data and numbers. The somewhat controversial assertion is the idea that for complex health interventions, oftentimes we're not really interested in numbers or evidence of that sort. What we're interested in is a deeper understanding of how the world works. So, with that in mind, in my view, the goal of many of these studies is exactly, Vince, the point that you're making, that we need to understand and identify all of the different factors and influences and, essentially all of the levers of change. And that our studies repeatedly over time should help us to develop pooled ideas that lead to a better DAG or causal diagram. Exactly which of those factors you need to bring to the table and what level of dose and so on will vary so often and so much by site that in some ways, you could almost say that our goal as researchers should be to develop the tacit knowledge and essentially arm decision makers with a better understanding of the world and the ability to monitor and measure their own effects and impacts. And this is the way that a lot of our quality improvement colleagues think about the world. We can't, develop a formulary or FDA-approved list of effective interventions. What we can do, perhaps instead, is ensure that decision makers, have an understanding of how the world works, have an understanding of the different factors they need to attend to, and that they can perhaps modify and influence, and the ability to very quickly in real time determine the effects of those changes and go back and titrate the intervention. So it again is a matter of understanding causality, developing tacit knowledge, and sort of the way that we raise children. We don't read the manual to determine which interventions are effective, because for some kids, heavy discipline is effective and important. For other kids, letting them make their own mistakes is important. You try some things, you see what happens, and that tells you whether you should try something else. So obviously the truth is somewhere between. We need the empirical data, we need some form of traditional evidence, but we can't neglect the importance of research that helps us to develop a better version of the causal model without necessarily, estimating the parameters along each of those different causal links.